Welcome to our monthly webinar series hosted, hold on one second. Let me go back to our main screen. Okay, here we go. Welcome to our webinar series hosted by the Office of Integrated Healthcare Research and Policy in the Department of Family Medicine at the University of Colorado School of Medicine. Let me begin by telling you a little bit about our sponsors and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. Cal Mesa is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by Cal Mesa are funded by counties through the voter-approved Proposition 63. The Mental Health Services Act. Prop 63 provides the funding and framework needed to expand mental health services to previously underserved populations in all of California's diverse communities. The Agency for Healthcare Research and Quality Academy for Integrating Behavioral Health and Primary Care functions as a coordinating center and national resource for people committed to delivering comprehensive integrated healthcare. The Academy focuses on integrating behavioral health care into primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders in integration. Key Academy tasks include the NIAC, the National Integration Academy Council, an expert panel of nationally recognized leaders in integrated healthcare, the Academy web portal and literature repository where there are over 1,900 citations, and the recently developed lexicon for behavioral health and primary care integration, and much more. Please visit www.integrationacademy.arc.gov for additional information on the Academy. The Collaborative Family Healthcare Association is a nonprofit, member-driven, collaborative organization in existence since 1995. CFHA promotes comprehensive and cost-effective models of healthcare delivery that integrates mind and body, individual and family, patients, providers, and communities. The Advancing Care Together project is a project of the UC Denver Department of Family Medicine, a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program, funded by the Colorado Health Foundation, has funded 11 demonstration projects that have been organized as a set of diverse comparative case studies and will be linked to support cross-project learning. Before introducing our presenter today, Dr. Neil Korsen, I would like to take a few minutes to go over housekeeping items for GoToWebinar. On the left hand of your screen will be the GoToWebinar control panel, where you can log on and use either your microphone and speakers or call in by phone. And on the next slide, you'll see an area where you can submit questions by chat throughout the webinar to be answered during our Q&A session. Today, we are pleased to bring you Dr. Neil Korsen. Dr. Korsen is a family physician geriatrician with 18 years of practice experience, mostly in small towns in Maine. Since 2001, he has worked for Maine Health, an integrated delivery system in southern and central Maine with a focus on assisting primary care practices to implement evidence-based systems of care for people with depression and other common mental health conditions. There, he is the medical director of the Behavioral Health Integration Program. He has received funding support for his work from the MacArthur Foundation, the Robert Wood Johnson Foundation, and the Maine Health Access Foundation. He has a number of publications in peer-reviewed journals related to behavioral health care and primary care. In addition to his work on integration, he also has roles related to shared decision-making and primary care transformation for the system. Nationally, he serves as a member of the AHRQ National Integration Academy Council, an expert panel working with AHRQ on developing resources related to integration. Today, Dr. Korsen will provide an overview of the Agency for Healthcare Research and Quality funded Atlas of Integrated Behavioral Healthcare Quality Measures and a sneak preview of Phase 1 of the Atlas project. Welcome, Dr. Korsen. Let me pull up.
Thank you, Emma. And good morning to most of you out there. Good afternoon to those of you who are on the East Coast with me. And I appreciate this opportunity to talk to you about the Atlas of Integrated Behavioral Healthcare Quality Measures, the next product that will be up on the Academy web portal that Emma described. The atlas actually ought to be available publicly on the website within the next month or so, and this is an opportunity to give a little bit of a sneak preview to those of you who are on the webinar today. So Emma, if you can go to the next slide, please. Thank you. This is just an outline of how the next hour is going to go. So I'll provide some background on the atlas. I'll talk about the lexicon and operational definition of integration and how that lexicon was used to create a framework for measuring integration. I'll talk about how we found the measures that will be available in phase 1 of the atlas development. We'll talk about measuring outcomes and where we are in terms of building that into the atlas. And I hope to get through all of that to leave a substantial amount of time for questions and answers and discussion. So that's where we're going. And Emma, if you can move on to the next slide, please. So this slide describes the reason that the atlas was developed, and as integration is a relatively new field, a lot of people are working on integration and are still interested in questions such as how do you measure integration as you're implementing to see if you're on the right track? How would an evaluator look at an integration service to determine its impact? And so this atlas is being developed. It's a dynamic process still going on, is being developed to meet those needs. And as you can see from the slide, the audience is those who are trying to implement integration, and also those who might be doing research or be involved in an external evaluation of integrated service. So that was the purpose, the stated purpose as we began to work on the atlas. Next slide, please. Thank you. So this is what the home page of the atlas will look like when this part of the website is up and running. This is the second quality measures atlas that AHRQ has supported. The first one that came out was the care coordination atlas that was out as we were beginning our work on the integration atlas. That was developed as a paper document, which also sits online, but our goal with the integration quality measures atlas was to create something that would primarily be web-based, and so the functionality is different from a document that sits on a website and that you work your way through sequentially. So our goal with the atlas was to make it very usable as a web document, to make it easy to navigate around the document to find the information you're looking for. We will, as the atlas comes out, have a variety of ways to get feedback from those who are using the atlas, because we consider this version 1 and we want to get your feedback so we can modify and improve the atlas and make it more useful to you over time. So next slide, please, Emma. This slide gives you an overview of the Academy web portal, the homepage for that. So just to give you a little background, this website has been up for probably close to a couple years, and the goal is for this to be the go-to place for people looking for information on the integration of behavioral health and primary care. And it's organized to provide information about the research base that was the first thing that was developed, and it has the published research. It also has what we refer to as the gray literature, so non-peer review reports and other things that are useful as background and information about integration that are not peer reviewed. You can see the other sections address issues of workforce development, education, policy issues, finance, the lexicon, which I'll talk about in more detail in just a moment, clinical tools, information technology, other resources. And this web portal, again, is really designed and intended to be not just a repository for information, but an interactive resource for the field of integration as a place to go and a place to share ideas and learn from each other. Again, the development of all of the functionality will happen over time. Next slide, please, Emma. So the lexicon, and just the term lexicon probably needs a little explanation for some people. So think of a lexicon as an operational definition. And again, the idea behind the development of this is, as a new field, the term integration is used for a lot of different types of activities. And in order to further create this field, what we want to do is have a shared definition so we all know that we're talking about the same thing when we're talking about integration. CJ Peak from Minnesota, who has been the lead on the development of the lexicon, a member of the National Integration Academy Council, likens it. He tells a story about in the early days of electricity, there were lots of different names for the various components of an electrical circuit, and there was a meeting that pulled together people in the field that came up ultimately with a shared definition of things like volts and amps and resistance. So we feel, CJ certainly feels, that the integration of behavioral health and primary care is a field that was in need of some common definitions, so we can both be clear when we're talking about an integrated service that we're talking about the same thing, and that if we're doing research to look at the impact of integration, we can define what type of integration is being done, so that we can look at the outcomes and identify what might work and what might not work as well. So we were able to use the lexicon as a way to develop our measurement framework. And that's because, again, consistent with what I was saying before, in order to measure something, you need to define what it is you're measuring. So, Em, if we could move on to the next slide. The next slide is the lexicon definition that was developed through a consensus process involving a lot of people and multiple iterations. This is a standard way of developing this kind of consensus definition. So I highlighted a few areas on this definition of integrated care that I think are important. One of those is that we were really talking about a team working together that includes behavioral health and primary care clinicians that are all taking care of a defined population and that share responsibility for that population. And then the other paragraph, which addresses the breadth of different types of conditions and problems for which integration might be used, we made an emphasis on this is not just about mental health and substance abuse conditions in primary care, but that there are other types of conditions and problems that lend themselves to an integrated approach. Just again, to take a step back, our use of the term behavioral health rather than some others was the result of a long discussion, somewhat contentious at times. Not we all got along fine, but we disagreed respectfully in terms of do we use the term mental health, behavioral health? Do people understand what behavioral health means? And we ultimately landed on using behavioral health because of the broad application we wanted, and we wanted this to be about health behaviors and other behavioral and psychosocial aspects of physical health care, and recognize that we would have to do work to make sure that all of our audiences understood how we were using the word behavioral. So again, just some background that's important. Next slide. Okay, so this is really about how we took the lexicon and translated it into a framework for measurement, and then identified measures that were related to that framework. So the lexicon served as a definition, and from that we were able to describe what are referred to as performance domains. I apologize for the jargon. My job here is to translate it into English for you. Performance domains, and you'll see an example in the next slide when we get there, but that really is the framework. That's the definition of integration that we use to look for measures. In order to get there, we need to take these domains, which are descriptions of certain components of integration, and translate them into constructs, which are things that you can observe or measure that tell you whether that thing, whether that domain is happening or not. So that's how you describe integration. So for instance, one of the domains has to do with the team, as you saw in the definition, the team of primary care and behavioral health clinicians. And so there, when you get to constructs, there will be structural measures which simply tell you whether there is, who's on the team, essentially. So who are the behavioral health clinicians who are on the team? But then in order to know if this is an integrated team, we also have to understand something about the process they use to deliver care. And that really gets at measures of how they work together. So the structural measure is there a team? The process measure is how does this team of people work together? Similarly, when we were looking at the framework with relation to screening for common conditions, a structural measure might be, is there a policy about who gets screened and how often? And then a process measure would be, how well is this policy followed? So again, that's the translation from domains to constructs. And then once the constructs were identified, the process of going to look for what measures were out there that could be applied to those constructs happened. So let's go from the theoretical to the actual on the next slide, please. I think it will make more sense. So again, you see just the example in front of you that the domain has to do with care team expertise. specifically the team is tailored to the needs of a particular patient population with a suitable range of expertise and roles, and then the constructs get down to how do you measure that as a structure, which is really are there the right team of professionals to meet the needs of that population, and then what are the processes that that team uses to work together to meet the needs of that population. So that's the framework that includes domains and constructs. And if you have questions, if I just confused you, we'll have opportunity later to answer those questions. So let's move along to the next slide, please, Emma, and we're going to talk about the process by which we looked for the measures that are the first phase of the atlas development. So obviously the lexicon definition informed our search strategy, and then as we searched, this is the royal we, there was staff that did this work. The one criteria was to look for measures that were in the public domain, because we wanted to provide within the atlas measures that everybody can use, and we didn't want the cost of the measure to be a barrier to being able to use it. There are some copyrighted or protected measures, but they're included only if you can use them without any cost. The other thing is we wanted measures that were still actively in use, and so the first pass on that was to look for only measures that were published in the last 10 years before this environmental scan was done, in order to include things that were still actively in use. Even if they were older, we also then included things, measures that fit our framework that may have been older but were still in use, and the evidence of that was that they were being used in recent publications. So that was the search strategy at a high level, and the next slide will summarize what we found. So in searching all appropriate sources of these kind of measures, there were 31 measures that were identified and brought to we had an expert panel specific to the development of the atlas, and it was this panel which looked at these 31. Some were removed because the expert panel did not feel that they really were appropriate to measure the specific constructs of integration. Some were removed because we couldn't get permission to use them. That left us out of the 31 initially identified with 17 that are included in the atlas. And of those, we consider 9 to be core measures, a few of which, but only a few, were developed with the explicit goal of measuring integrated behavioral health. The rest of those core measures addressed many, if not all, of the components of the measurement framework. The 8 other measures, and we considered a few different names for them, other measures was the most generic and actually made the most sense, only have a few items. So these are measures that might only have a few items that apply to integration, probably just to 1 or 2 of the measurement constructs, but we felt were useful enough to those who might be looking for measures that we should help people to know about those as well. So the next slide is to begin to show you how we set up the functionality of the atlas, and this would be the page. So you can see that to navigate the Academy website, the atlas is listed under resources, and that when you click on the atlas tab itself, you can see the organization that includes this page, which is called Find a Measure. So there's some of those other tabs would get you to more background information and overviews, a guide to using the atlas, and for those who are interested, more detail on methodology. So the Find the Measure page, there's a couple different ways. If you come and you know what measure you're looking for and what you're interested in is more detail about that measure and how it might be used and uh, how we saw it mapping onto the measurement framework, you can click and go directly to a measure. If instead you have an idea of what aspect of integration, what part of the framework, in other words, what functional domain you're interested in measuring, you can find measures that are related to that particular functional domain. And then finally, if you're coming and saying, I'm I'm doing integration in my practice or in a group of practices, and I need some help figuring out how to measure, uh, you can identify what your goals for measurement are, and the atlas will help direct you to the measure or measures that you may want to use. So the next slide will show you uh, what you can find if you go to the search by measure. So here, again, you've started by saying that I want to look at the behavioral health integration checklist, the one that's highlighted there under the list of the 9 core measures, and that then takes you to a page with a template that describes this measure, what its purpose is, who developed it, when. Uh, you can see the headings there, and then at the top you see there's a PDF, so you can click on that and actually get to look at the measure itself. So for somebody who's looking for a measure, this is the kind of detail you get once you find the measure that you're looking for. We don't have a similar example of how to get to a measure through functional domains or guide me, but the atlas will be available to you soon, and you'll be able to play around with that yourself. Next slide, please. Thank you. So this, we anticipated that this would be one of the first questions, so we figured we'd take care of this one without it needing to be asked. So you will see that in the first phase of the measure, most of these are measures that describe the structures and processes of integration, not not the impact or outcomes. We did look for patient experience of care outcomes, and what we found is included. This was because we think about the measurement of integration as really being a two-step process. That in order to measure, to compare integration activities, you have to be able to, number one, describe what's going on in terms of integration, and secondly, you then need to look at the impact of what activities, what services you're providing. And our focus in the first phase, version 1, was to mostly offer the measures that will allow you to describe the integration activities that are going on. And then as we get into the next phase, and there's discussion about the details of that going on, that just even within the last hour, I was on a call. So that is where we will be providing much more information about the measuring the outcomes of integrated care. So I'm ready for the next slide. Please, Emma. So a lot of people worked hard and did excellent work to create the atlas that will be up on the AHRQ website very soon. And uh, I think it's important to acknowledge that, starting with our AHRQ officer, Charlotte Mulliken, who really has been the driving force behind the entire Academy, the Academy web portal, and all of the activities, uh, some of which I showed you in previous slides. Westat is the task order contractor with AHRQ, and the staff from Westat have been doing all the hard work in gathering the measures, putting this web-based atlas together, and have done wonderful work. CJ Peak, in his leadership on the development of the lexicon, created the resource without which we couldn't have done this. Ben Miller, who may be listening in, so I may try to embarrass him. Ben really has been the driving force behind AHRQ taking on integration as an important topic, and without Ben, we wouldn't have had the opportunity to do any of this, and we all appreciate just how energetic Dr. Miller is. The people at the Ames Center, which is at the University of Washington, Dr. Unitzer and his colleagues uh, are responsible for the dissemination work on this phase one of the Atlas, and there's been a separate expert panel working under the direction of Jürgen Unitzer and Kitty Christensen that are still doing their dissemination work. Next slide, please. And then hosts of others, as you can see, who've helped us with this work, including the expert panels, both the National Integration Academy Council, which is the ongoing group working with AHRQ, people who were part of one of the two expert panels specific to the Atlas, those involved in development and those involved in the dissemination planning. And those folks are all mixed on this slide, and all of them contributed importantly to this work. So we got through that pretty quickly, didn't we, Emma?
We did. So we have plenty of
And
time for questions.
so I assume you'll manage that, and we'll answer the questions you have.
Yes, that would be great. So, as you know, you can submit your questions by typing in the chat box, or you can raise your hand and I will unmute you, and then you can ask them that way. So let me read you the first question. You describe the measurement of integration at two steps. First, understand the implementation of different integration components and measure the process. The second measures impact and outcomes of integration. How long does it reasonably take to arrive at a point where a practice or program can begin measuring outcomes and expect to see change?
That's a great question. My answer will have to be approximate because I think it's always going to depend on how quickly you can implement and have enough impact on the process of care to think about outcomes of care. So I'll use our own work as an example, and I think it'll point out a couple of the measurement challenges that I suspect many of us are up against. We at the health system where I work began integration with grant funding as a pilot something like 6 years ago. And during that pilot time, because funders always want you to measure what you're doing, we were doing some measurement that I think was probably unrealistic to do long term if what you're doing is providing a clinical service and measure it, but important to do when you're doing pilot work. That funding ended a couple years ago, and we are now providing integration as a service that practices pay for the clinician, pay a little bit for our help in implementation. And up to this point, and I would say we're early in implementation, many of our sites have only been up and running a year or two. We're mostly still focused on process measures because we're mostly still trying to make sure that implementation gets done as effectively as possible. We want to look at uh, is the clinician getting enough referrals? How's their no-show rate? Are they generating enough income to be self-supporting? One of our challenges in getting to outcomes as opposed to still measuring process is our data systems don't easily measure a lot of what we would see as the most important outcomes, whether those are clinical, functional, or financial. Some of it, and you'll see when the atlas is live, some the outcome measures for things like patient experience are really not yet developed. So I'd say that the delay in getting from process to outcomes might be due to your data systems, might be due to waiting for the impact to happen, might be due to not exactly having the right measures for the kinds of outcomes we want. I think you're probably looking at years, not months uh, after starting an integration program before you can really expect impact on outcomes. I hope that's what you were looking for, and I hope it's not too discouraging.
Right, our next question, Dr. Korsen, how do you foresee our communities using this tool? With more folks tackling integration, it seems to be a critical time for consistency in how we measure integration.
Um, what we all hope, and you saw the long list of people who've been working hard on this, is that those who, like me, are doing integration in real practices while we speak and wondering how to measure what they're doing and the impact will go to the atlas and find the measures that they need. I'm going to speak on what I would imagine we want this to be. This is not yet approved, so you're hearing my wish list in my head, not anything that you necessarily can expect. But one of the things that we've at least talked about as we go into the next phase of Atlas development would be to have something that you might think of as a starter set. So if you're a practice and you just want to get started, well, here's a list of things that you can use to measure the processes and the outcomes. And similarly, if you are hired as an evaluator by an organization, so we would hope that for those who are actually on the ground doing the work, that whether it's by using the atlas to put together your own list of what you want to measure or going to the atlas where you can be given a default list that you can start with, that we will help you answer the question of how do I know what kind of integration we're doing, how successfully it's been implemented, and what kind of impact it's having. We also hope, I don't want to, let me just add this, that as you use it, you'll tell us what else you would like. And I expect you'll see when the Atlas goes live that there will be a mechanism, one or more mechanisms for you to give us your feedback and tell us what else you need.
Dr. Korsen, when will the website be fully functional and is there expected date of delivery of the atlas?
The Atlas, the final review by AHRQ and HHS is happening as we speak. My understanding is that process takes a few weeks, and so I would expect that by sometime in July you'll be able to find the atlas on the Academy web portal. And if you haven't checked out the web portal in general, I would encourage you to do that. And then if you just check every so often, maybe every week or so, I will be surprised if you don't find it by sometime in July.
Great, thank you. Related to the timing of phase one versus outcomes, at what point do you establish a baseline?
I think that you would ideally like to have baseline information relatively early in your implementation. Data collection can be a challenge. Again, part of that depends on your data systems, but uh, you would want to collect some baseline data about whatever aspects of integration you want to measure. I would think within the first few months of implementation, right beforehand if possible, but you also have to do what's feasible within your organization.
Thank you. And we've received a couple questions asking if there's a way to receive an email notification of when the Atlas is live. Is there any listservs or anything participants could get onto?
I'm I would think that we'll probably put out, there will be some sort of notice put out. I'm not sure of a specific website. I think about the Collaborative Family Healthcare Association that does have a listserv, and certainly we would want that group to know. So I apologize. I don't know if there's any easy way. Emma, is there any way to follow up with webinar participants to get them a better answer than than what I know right now?
Yeah, I think so. And also, two of our sponsors for this webinar series is the Collaborative Family Healthcare Association. And if you go to their website, which is cfha.net, you should be able to enroll into their email listserv. There's also the Agency for Healthcare uh, Research and Quality News Blast, which I am fairly certain you can access from their website, as well as our other sponsors, CalMesa. And a participant has just said that the National Council may disseminate
Right.
information
I
through
know the
there.
National Council has a website, and certainly they've been doing good work on integration as well. And I know we're trying to highlight each other's work on that. So that's a good idea.
Great. And we have a few more minutes, so if you do have a question, please send it in. Dr. Korsen, in doing the environmental scan for measures for this tool, what surprised you the most? What do you think about what did you think about what was said about the state of the field?
Well, I wouldn't say this was surprising, but I'm sure it's obvious to all of you that there was a relative lack of measures. There especially was a lack of measures that were specifically developed for integration. Not everything on the list has full validation as one might do for in survey research, so that within that list of even 9 core measures, you have some that are not valid, other than they have face validity. They clearly measure aspects of integration, but they haven't gone through a formal validation process. So I think what this tells me is there's great opportunity out there for people interested in integration, and this is perhaps one of the ways that a researcher might find the atlas useful, is to look as much at what isn't available in the atlas as what is, and think about opportunities to fill those gaps by creating new measures.
Thank you. In the course of developing the Atlas measures, was there any vetting by applying it retroactively to clinical sites that had been settings used in earlier or recent work on relative outcomes of delivering integrated care versus the control standard practice?
Nothing like that has been done in the process of the development of the Atlas. Certainly, some of the measures that we found have been used either in research or quality improvement activity. So there may be, I suspect there is some experience. I know, for instance, one of those 9 measures is something called the site self-assessment, and that's one of the things that we used. It was developed by folks in Maine. It was a modification of a modification of a measure called assessing chronic illness care, which some may be familiar with, that was used uh, back in the day when the chronic care model was relatively new and organizations were implementing the chronic care model and then looking at uh, whether how well the systems had been implemented. So this site self-assessment looks at 9 clinical and 9 system level components of integration, and I know that in Maine, those were SSAs were collected across dozens of organizations that were funded by the Maine Health Access Foundation. It's also now being used as part of our patient-centered medical home pilot at the state level, so that we now have 70 some primary care practices that are filling SSAs out periodically. So I think we, in Maine anyway, will have a chance to do exactly what you're suggesting. But in terms of any formal process like that, nothing in the Atlas development. That was a long answer, maybe a little bit rambly, but hopefully it met what you needed.
Great, thank you. And here is what will be our final question for today. Are there any plans to develop outcome measures if there are not any in the current research efforts?
I think the any plans is hard, because the next steps in terms of our discussions with our friends and supporters at AHRQ are still in process. Uh, there there has been some discussion, for instance, in the realm of patient experience, that we see an opportunity to try to develop measures, at least questions about patient experience, potentially a module within something like a CG CAPS type of survey that could be used explicitly for integration. That is still an idea in the talking about stage that would then have to move to write a proposal and get it funded stage. But there's definitely, certainly within our group, we've had some discussion about what gaps in the measures we might be interested in filling. In terms of outcomes, and in particular clinical outcomes, the discussion so far is that outcomes for a lot of the clinical conditions that might be addressed by an integrated service, there's measures out there already, and our job will be to help those who are doing integration identify what clinical outcomes they might want to measure, and then help them direct them to the sources of those measures. Because I don't think integration changes the outcomes we want to measure. It really changes the processes by which we try to achieve those outcomes.
Well, thank you everyone for joining us today, and thank you again to Dr. Korsen. Please complete the short evaluation that will pop up after the webinar ends. And I hope you are all able to join us for our July webinar, which will be with Dr. Roger Cathall on alternative payments for sustaining integration. Have a great day.
Thank you, Emma.
Thank you.